the organizers, and thank you, PU, for your very kind remarks. I hope you're all able to see and hear me clearly. It's always an honor here to speak in the Skin of Color presentation here. I thought I'll talk about the basics of the skin cancers and skin of color today. This is a topic which I spoke on for Melanoma UK a couple of years ago. And when I was researching the topic, I found that many of the things, the facts that I took for granted were actually wrong. And I discovered quite a few facts about skin of cancer and skin of color, which I'd like to share with you today. So why is it important to know about skin cancers and skin of color? So we need to know that the demographics of the world is changing. We are becoming a global village. There's so much of migration from various parts of the world towards the West. And there is increasing skin of color in places where we live. If you look at the world as a whole, there are more people in skin of color than white skin. White skin, in fact, is a minority. You may argue that we are living in the West, and in the UK and in the US, there's less people with skin of color. But even here, there is a change. For example, in 1990, there was 76% of white skin in the US. By 2050, they will be a minority. Similarly, in the UK, Leicester already has more people with skin of color than white skin, and Birmingham will soon be following it. Unfortunately, though, even though there's increasing amount of skin of color in the West, we still have very limited information in the literature. And that's something we probably do need to try and correct. As I mentioned before, there are so many unique aspects in the etiology and the clinical features in skin of color, particularly with skin cancers, which is distinct from Caucasian skin. And that's what I'd like to share with you today. This is a very interesting article, a perspective piece, which actually came up just before the pandemic. And it was a wonderful piece, which I really enjoyed reading in the British Journal of Dermatology. The authors are from America, and they mention 2 or 3 ways by which underrepresentation of skin of color in dermatology images can affect us. The first thing is, it does affect the physician-patient relationship. Usually people with skin of color suspect authorities. They're usually of lower socioeconomic classes, particularly in the US. And therefore, if we as doctors do not have the confidence of treating them, that relationship is likely to be eroded. The second point the authors mention is that it can affect the way we train our trainees. If we don't know much about skin of color, how can we teach our juniors? So for that reason, again, there is a requirement for there should be an increase in the amount of skin of color pictures available to our trainees. And finally, it does affect the integrity of our field of dermatology itself. I mean, we are supposed to be an inclusive specialty. If we focus all our images on white skin, then how can we sort of use dark skin as an example? We have to try and increase the scope by which we can treat all patients equally. So this is a fantastic piece of literature, which was there in the BJD just a couple of years ago. Coming on to skin cancers, it is the most common cancer in the US and probably in the UK as well, where 30% of cancers are from the skin. And it is much less in dark skin. If you look at Asian skin, only 2 to 4% of cancers are from the skin. So if you look at the incidence, Caucasians are 70 times more likely to get skin cancers compared to those with darker skin. And we come to the topic of ultraviolet light, and this is very important because I was always of the view that ultraviolet light is the most important factor for all skin cancers in all colors. But there may be a little bit of information that we may need to consider before we come to that conclusion. In white skin, it probably is the most important factor. We know that from clinical experience, we know that from studies, because as we go closer to the equator, as there are fairer and fairer skin, then the chances of skin cancer increases. And this is all skin cancers, whether it's basal cell carcinoma, squamous cell carcinoma, or melanomas. The more sun exposure you get, the fairer your skin, the more likely you are to get skin cancer. And you can also see that in clinical practice because most skin cancers come in the sun exposed areas, in the face and the neck. But is that true for skin of color as well? You have to take into consideration that those with skin of color, their melanin protects them. They've calculated that if you have skin type 6, you have an inherent SPF of 13. Now, this is naturally going to be protective against excessive sun damage and sunburns, which is the most important factor giving rise to skin cancers. The melanocytes, even though we all have the same number of melanocytes, the number of melanosomes and the distribution of the melanosomes is different. The reason people with darker skin appear dark is because their melanosomes are darker and they are more well distributed. So this does have a protective action against skin cancers, particularly against sunburns. Now, if you look at it in an even narrower spectrum, even in skin of color, basal cell carcinomas are likely to be sun exposed due to sun exposure. So if you look at BCCs, it again comes in the head and neck areas. And the lighter you have, this lighter skin you have, for example, the lighter Asians are more likely to get BCCs. And the higher incidence also is noted as you come closer to the equator where there's more sun exposure. However, for squamous cell carcinomas and melanomas, this may not be the right etiology. And this is possibly the best analysis of the effect of ultraviolet light in skin of color. This came up in 2021 in the JAMA Dermatology, and it was an extensive meta-analysis where the authors looked at nearly 11,000 records, and they found 7,700 patients who had melanomas. They then looked at the studies which looked at the etiology, and they found that 13 studies met the criteria, and of the 13, 11 studies found no association between light, which is ultraviolet light, and melanomas. There was one study which showed a weak association in black skin, and similarly, one which showed a very small positive relationship in Hispanic males. So, is ultraviolet light the main factor for melanomas in skin of color? According to the author, they feel it is not. They feel that ultraviolet light is less important in skin of color with melanoma etiology. You may argue that there is an American study and it does not have relevance to other parts of the world, but studies from East Asia also did not show a link between sun exposure and melanomas. They do argue that there is a small subset of people with skin of color, perhaps if you're immunosuppressed or you've had infections, chronic inflammation, and scarring, that may predispose you to melanomas in spite of not having ultraviolet light. So I'm going to look at 4 main skin cancers today, and we have that basic background of how ultraviolet light may not be that important. And I'm going to go to the first question, which I'm going to pose to everyone. So this is the first question. In skin of color, which skin cancer has the highest incidence in blacks and Asian Indians? So can you choose between A, BCC, B, SCC, C, malignant melanoma, and 4, angiosarcoma? I'll just give you a few seconds and then we'll look at the answers. Yeah, shall we go to the next question? So most people have had BCC and some people have said SCC. Okay. So this is something which I'd learned as well, and it's actually SCC, which is the most common skin cancer in blacks and Asian Indians. BCCs come second, and then melanomas and T-cell lymphomas. And that's what I'll be talking about, starting with SCCs first. Let's go to the next question on SCCs itself. In skin of color, what is the most important risk factor for SCCs? Is it A, ultraviolet light? Is it genetic factors? Is it C, chronic inflammation and scarring? or is it smoking? So again, I'll give you a few seconds. Is it light, genetics, chronic inflammation, or smoking? Yes, can we see the results now? So most people have got it right. It is chronic inflammation and scarring. So the commonest cancer in skin cancer in Blacks and Asian Indians is actually a squamous cell carcinoma. It contributes to about 40 to 60% of the total skin cancers. In comparison, in white skin, it's 15 to 20%. And an unusual thing about squamous cell carcinomas and skin of color is that it's in protected areas. It's not in sun-exposed areas as it is in in Caucasian skin. And the risk factors, as you rightly said, is different. It's not ultraviolet light, it's chronic inflammation and chronic scarring. Now, these typically occur in thermal scars, in radiation scars, or in chronic inflammatory processes like discoid lupus erythematosus and hidradenitis suppurativa. One very important factor is how aggressive these SCCs tend to be. If you look at metastatic rate in white skin with actinic damaged skin, it's about 2 to 4%. In SCCs coming from a background of chronic inflammation, it's 20 to 40%. So you can see that it's a lot more aggressive, and therefore picking it up early is the most important way by which we can manage these patients effectively. Just like any other SCC, it starts as a small spot, it ulcerates because it grows so rapidly. But as I've mentioned before, this non healing ulcer on a background of inflammation and scarring is by far the most important clinical feature you will see in skin of color. The typical feature is usually hidradenitis suppurativa. You will see the chronic sinuses and other parts of HS like nodules and comedones. But within that, if there is an ulcerated or eroded area and it never heals, we do have to suspect, is there an SCC going on in the middle of that area? And we need to pick it up quickly because, as I've said, there is a much higher rate of metastasis. Discoid lupus erythematosus seems to be particularly aggressive, so do look out for any non-healing lesions in discoid lupus. There was a study in America which suggests that 60% of SCCs in skin of color occurs in the lower limbs, and in another series in the US, they found that 23% occurred in the perianal area in women. So very, very unusual sites compared to the head and neck in Caucasians. And this is an SCC occurring in the lower limb. You can see that the pigmentation is obvious in some parts of the SCC. And this is SCC occurring in a background of hidradenitis. This is actually the perianal region, and you can clearly see a verrucous growth coming from the background of HS, and this was an SCC again. Another it's unusual here, but it is a common fact in the subcontinent. There's arsenical keratoses, which is very common in Bangladesh. And this is because in Bangladesh, there's a very high concentration of arsenic in the groundwater. So we have seen loads of Bowen's disease and SCC coming on this background of those who are coming from the subcontinent. So do think about arsenical keratoses causing SCCs in anybody coming from the Bangladesh area. The treatment is exactly the same. We treat with surgical excision and radiotherapy, but the prognosis is quite different. Because we miss the diagnosis, because it's so non-specific as an ulcer, we tend to see it in more advanced cases, and therefore the diagnosis is delayed. And the metastasis, as I said, is much higher. It's 20 to 40%, which is significantly higher than what we would see in clinical practice in Caucasian skin. Next, let's go on to the basal cell carcinoma. I have another question here. So, in skin of color, basal cell carcinomas, are they more common in males? Are they more common in females? Or is there an equal incidence? I'll give you a few seconds to answer this question. Are they common in males, females, or equal incidence? Yeah, can we see the answers now? So most said it's in males, some females, and some said equal. So these questions are the ones I got wrong when I was researching this topic. Actually, it is equal incidence in those with skin of color. Now, if you look at BCCs, again, it depends on how much of pigment you have in your skin. If you have fairer skin with Asians, for example, the Chinese Asians and Japanese, this is the commonest skin cancer. But if you look at darker skin, blacks and Asian Indians, it's the second commonest skin cancer. And unlike Caucasians, where it is much commoner in males, it is equal incidence in males and females in skin of color. It is more with sun exposed areas, so there is a correlation between ultraviolet light and BCCs, but not NSCCs and melanomas, as I've mentioned before. It looks just like BCC in Caucasian skin. It starts as a pearly, translucent lesion. It grows very slowly compared to an SCC, but the difference is that it can be pigmented. If you look at Caucasian BCCs, it's 5% of pigmented BCCs. But if you look at BCCs in skin of color, more than 50%, some people say even up to 80%, can be pigmented BCCs. So that's clinically a big difference. And it has that sort of pearly hue. This was a pigmented BCC. You can clearly see it can be missed as a seborrheic keratosis, but the pearliness gives you a clue. And as Jonathan said, there may be some features under dermoscopy which may be helpful as well. Here's a picture from one of my father's collections, and there's a lady who's had multiple BCCs which are all pigmented. These were thought to be seborrheic keratoses, and one of them, in fact, one of the forehead, one of the physicians had actually tried to freeze it, thinking it's a seborrheic. But it's got that pearly hue again, which gives you a hint that this could be a BCC. The treatment exactly the same as what we would do here: surgery, and in superficial lesions, topical imiquimod, and radiotherapy in some cases as well. Going on to the next question, we're going on to melanomas now. In skin of color, what is the commonest site for melanomas? Is it the sun-exposed areas, the face, the trunk, or is it the acral area? So in melanomas, in skin of color, where is it most common? Is it in the sun-exposed area, the face, the trunk, or the acral area? Can we see the results again? So most of you got it right. It is in the acral area. Here again, it seems that we missed the diagnosis, but again, the incidence is much lower in dark skin than in white skin. We've already told you why that could be the case. It's because the melanin protects us, but it's this unusual distribution which makes us not think of melanomas as the first diagnosis, and therefore the diagnosis may be delayed. The risk factors are different as well. It's not sun exposure, it's burn scars, it's radiation treatment, trauma, immunosuppressed. And there is a small cohort, maybe 20 to 40%, where it does come from a pre-existing pigmented lesion. Here too, the pre-existing pigmented lesion tends to be more in the acral area. So it is slightly different in where you get the lesions. It's not on the head and neck, it's not on the trunk, but it's much more in the distal areas. And it also occurs more commonly in the mucosal areas. So as I said, it's non-sun exposed areas: acral, mucosal, and subungual. Now, if you look at these sites, these are the areas which don't have color. So the palms and the soles, the place under the nails, the mucosa, they don't have color. And that may be the reason why melanomas tend to occur a bit more commonly in these areas. If it comes from a pre-existing mole, it would behave exactly as it would in Caucasian skin, a mole which is changing in color, shape, and size. Oral melanomas tend to be much commoner. 7.5% of melanomas in skin of color are coming from the oral area. And the plantar areas, 30 to 40%, where it gives you the acral lentiginous melanoma. So unlike Caucasian skin, where you get superficial spreading melanoma, here it is acral lentiginous melanomas. And those are typical features where it completely erodes the nail. So I think Jonathan mentioned that it can affect the fragility of the nail. So because the matrix is involved, it completely destroys the nail, and you can get Hutchinson's sign as well. Of course, the most common, the most well-known melanoma is Bob Marley. He thought he had a football injury. He thought he had an ulcer on the toe because he had injured it. But unfortunately, it was a malignant melanoma, and he died when he was in his 30s from metastatic melanoma. There's one of my colleague, Dr. Ravichandran's patients. He'll be lecturing to us tomorrow on vitiligo surgery. And again, you can see that it doesn't have much pigment at all. There's a rim of pigment in one side, but it's an pink nodule, not a pigmented nodule, and it's again on the palm. So we do have to have quite a high degree of suspicion in these lesions to pick up a melanoma. The treatment is very similar. We use surgery, wide local excision, sentinel lymph node biopsy if the Breslow thickness is higher. We can use immunotherapy and BRAF inhibitors, but there is another mutation we should look for, and that's the c-KIT mutation. And this is because with oral mucosal melanomas, c-KIT mutations are much more important than BRAF mutations. So again, in the workup of patients with skin of color, we have to widen the investigations that we do. We can't just do BRAF. We have to do c-KIT as well, because there is treatment for it as well. We can use imatinib compared to the BRAF inhibitors. So our management changes slightly in skin of color melanoma patients. Unfortunately, we all miss it because it's hard to diagnose, particularly when it's very subtle. It's therefore more advanced, thicker melanomas that we diagnose, and therefore there's a higher mortality. There does seem to be some effect between socioeconomic status and the incidence of melanomas. Most of the data is from the US, where people with darker skin generally tend to have less health cover, and therefore they have a much poorer prognosis. Unfortunately, there seems to be some problem with AI as well. I think Jonathan mentioned this as well. AI, unfortunately, mostly works on images from Caucasian skin. There is not that much of information with pigmented skin. And there's, again, an excellent commentary from the US where they feel that disparities in healthcare is being written into code in AI. And this is something we probably do need to think very hard about as dermatologists. How can we rectify this disparity in skin of color, particularly with skin cancers and AI detection of skin cancers? So let's go on to the next question. So in melanoma prevention in skin of color, what should we focus on? Is it A, avoidance of sunburn, B, protection from the sun, C, mucosal examination, or D, smoking cessation? So is it sunburn avoidance, protection from the sun, mucosal examination, or smoking cessation? Yeah, can we have the results, please? Yes, most of you got it right. It is mucosal examination, as we've discussed now. So the way we educate people should change. If you look at most of the melanoma prevention leaflets, they only mention sun damage. But the way we educate people should change, because it is not sun exposure alone which is the problem. It is the distribution and the way it presents which also needs to be taught to the public. So when we see a person with skin of color, we should ask them to examine certain sites which they normally wouldn't think of: their palms, their soles, under the nails, in the mucosa, and also in the genital mucosa. And this is the way we should examine in skin of color. And also we have to involve other specialties: the oral medical people, the dentists, the ophthalmologists, and the gynecologists. So the way we preach about public prevention of melanomas has to change, and our leaflets has to show that as well. Finally, very briefly about cutaneous T cell lymphomas. I'll only be talking about the clinical aspects here. We know what cutaneous T cell lymphomas are. They're just abnormal T cells which, instead of going in the bloodstream, home into the epidermis. So that's called epidermotrophism. But when they come into the epidermis, they do cause quite a lot of pigmentary changes, and this can be increased or decreased pigment in the skin. So The main factors to look out for with cutaneous T cell lymphoma and skin of color is the increase and decrease pigmentation. There's also more pruritus. There's much more inflammation and lichenification, post-inflammatory lichenification. And very commonly, it mimics eczema and psoriasis, just as it does for Caucasian skin. And the classical pattern is, we all know it, the arcuate plaques with scales, the poikilodermatous patches, the atrophy in the patches, and polymorphic pigmentation. So let's look at a couple of pictures. So these big patches, which is the bathing trunk area patches, with the atrophy on the surface, should make us think about cutaneous T cell lymphomas. And again, the poikilodermatous appearance with increased and decreased pigmentation is also quite clearly visible. And sometimes it can look very bizarre, almost depigmented areas along with hyperpigmented areas. And you can see how difficult it is to diagnose cutaneous T cell lymphomas. Again, there's the triple whammy here. There's a higher incidence in darker skin. It's a more aggressive cause. And because it's missed, there's a higher mortality as well. So all the more reason why a very, very high index of suspicion should be kept before we diagnose this condition. So the conclusions are that skin cancers generally tend to be missed. We don't suspect them because we think it's unusual, and the presentation itself is different compared to Caucasian skin. And because we miss the diagnosis, our treatment's delayed as well, and therefore the prognosis is worse as well. So the main way by which we can help as dermatologists is we have to have healthcare campaigns which look at these factors which we've mentioned here. It's not just sun exposure, it's the way we examine our patients and the way we ask our patients to examine themselves. And as I said, many of the facts which I've mentioned here, I was not aware 18 months ago. It's only because I researched the literature that I came to know about these facts. And therefore, if you can spread the information about these slightly unusual features in skin of color, skin cancers, that would be the best way that we can serve our patients. Thank you for your attention. I'm very happy to answer questions.